Hi, my name is Sevak Olmesekyan, and I'm here to present the case of Richard Taylor. Richard Taylor is a 57-year-old Caucasian gentleman who presented to the emergency department earlier this morning with the complaints of cough, severe shortness of breath, and increase in production of sputum. He has noticed recently that his spit is thick, greenish brown, and smelly, and he states that he has had serious troubles breathing at home, and he states that he can't seem to catch his breath. RT has had a long history with our outpatient family clinic, followed by Dr. White, in which he is actively being followed for COPD, depression, and CKD. He has a reasonably recent history of myocardial infarction in 2015 that did not result in congestive heart failure, and last known ejection fraction from earlier this year was 59%. He has successfully managed by multidisciplinary team for this depression and COPD at that time, and he was able to successfully quit smoking in 2019. In terms of his COPD, this is his third exacerbation within the last year. He has been reporting increased shortness of breath at rest, and a recent CAT test after his last admission in January demonstrated a total score of 26. His past medical history include obesity, dyslipidemia, COPD with smoking 1 pack per day history for 10 years, who quit in 2020. His social history include a former smoker, and his wife passed away in 2016. He uses alcohol occasionally, and he has decreased sleep due to shortness of breath. He is on DASH diet, and he does not exercise. His family history is consistent with CV disease and depression. His vitals, blood pressure is 139/89 and 141/91 when repeated. Pulse is 81, temperature is 98.8 degree Fahrenheit. Height is 6 foot 1 inches and weight is 184. His current medications that have just recently started are methylprednisolone 500 milligrams Q6 hours IV for 14 days, and 2 doses have been given. Albuterol and ipratropium nebulizer, 1 nebulizer every 6 hours. Heparin 5,000 units sub-Q 3 times a day. Metoprolol succinate 200 milligrams daily. Albuterol 2 puffs every 4 hours as needed for shortness of breath. Atorvastatin 80 milligrams once daily. Aspirin 325 milligrams daily. Vilanterol, umeclidinium, which is an oral inhalation, 1 inhalation once daily. Bupropion XL 300 milligrams daily, and he is allergic to adhesives. In prioritizing his problem list, on a high priority list are the chronic COPD exacerbation and his hypertension, and moderate is his history of MI, dyslipidemia, obesity, and smoking history. In assessment of the disease for chronic COPD, based on the GOLD criteria, this patient's FEV1 predicted score of 45 categorizes him as GOLD 3, which is severe, and his dyspnea, chronic cough, sputum production, and history of exposure to risk factors such as cigarette smoking, as well as a spirometry rate of FEV1 over FVC of 0.54 is a confirmation of COPD diagnosis. Patient is grouped in GOLD Group D based on his frequency of exacerbation history, this being the 3rd time within the last year. And the goal of therapy is to relieve symptoms, reduce risk of exacerbation and mortality. In assessment of his drug therapy, his current drug regimen of albuterol and the Anoro inhaler is not sufficiently controlling his COPD, and short-acting beta-2 agonists with or without short-acting muscarinic agonists are preferred bronchodilators for chronic obstructive pulmonary disease. Exacerbations based on GOLD standards is an evidence C. And according to GOLD recommendation, systemic corticosteroids should not be given for more than 5 to 7 days, even though European Respiratory Society and American Thoracic Society guidelines suggest a course of therapy of 14 or under days in duration. But the dose of methylprednisolone, regardless, is higher than the recommended range, since lower doses of 60 milligrams IV 1 to 4 times a day have had the same therapeutic effect with lower side effects. So for recommendation for the chronic COPD, we need to assess patients' airway, breathing, and circulation, and secure if necessary. We need to provide supplemental oxygen to treat pulse oxygen saturation of 88 to 92%, or PaO2 of 60 to 70 millimeter mercury. And Venturi masks are preferred means of oxygen delivery because they permit a precise delivery fraction of inspired oxygen. And we need to provide combination of aggressive bronchodilator therapy and ventilator support, invasive or non-invasive ventilation. For monitoring, we need to monitor for efficacy as improvement in oxygen levels, and for safety, we need to monitor blood gases. Second recommendation for COPD is a short-acting beta-2 agonists with or without short-acting muscarinic antagonists, which are preferred bronchodilators for chronic COPD disease exacerbation based on GOLD guidelines. So therefore, we need to initiate albuterol nebulization at a dose of 2.5 milligram, which is diluted to a total of 3 mLs every 1 to 4 hours. And for monitoring efficacy, we need to monitor the FEV1, peak flow, and other pulmonary functions. And for safety, we need to monitor the blood pressure, the heart rate, CNS stimulation, arterial or capillary blood gases. The third recommendation is a systemic glucocorticoids when added to a bronchodilator therapy improve symptom and lung function and decrease the length of hospital stay. The IV glucocorticoids are typically administered to patients who present with a severe exacerbation or are unable to take oral medication. We need to change the methylprednisolone dose to 60 milligrams IV 1 to 4 times a day for 5 to 7 days based on GOLD guidelines recommendations. And we need to observe patients' response to the therapy, and the therapy may be extended to up to 14 days if necessary, and that is based on the recommendation of European Respiratory Society, American Thoracic Society guidelines. And results of the SCOPE trial does not support treatment benefits beyond 14 days. And for monitoring, for efficacy, we need to monitor improvement in the COPD exacerbation symptoms. And for safety, we need to monitor blood pressure and intraocular pressure and thromboembolism. In assessing the disease of hypertension, according to the ACC-AHA guidelines, patient's current blood pressure reading of 139/89 categorize him as stage 1 hypertensive, but his reading of 141/91 as stage 2 hypertensive. And it is recommended that the higher of the two readings be used for categorization. So therefore, this patient is categorized as having a stage 2 hypertension. And as per ACC, AHA, JNC 8, and ASH-ISH guidelines, his goal blood pressure is less than 130/80, and the goal of therapy should be to reduce overall risk of MI, heart failure, stroke, or death by lowering the blood pressure to under 130/80, and should be started on 2-drug therapy. This patient has a compelling condition of post-MI for which the recommended treatment must be a beta blocker, first with an addition of an ACE inhibitor or an ARB. The contributing factors for his condition are his age, obesity, dyslipidemia, smoking history, and history of MI, and of course COPD. In assessment of the therapy, this patient's cohort 10-year estimated ASCVD risk factor is estimated to be at 7.4%, and patient's monotherapy with metoprolol is not sufficient and not the recommended choice of therapy. As per ACC-AHA guidelines, the treatment should include a combination of 2 medications from different classes, including an ACE inhibitor or an ARB. ACE inhibitors might be less desirable in COPD due to the slight possibility of COPD exacerbation. And the physician's consideration of switching metoprolol to carvedilol is not currently recommended. Use of carvedilol could be well tolerated in patients with COPD, but there is not much data available to show safety and efficacy in patients with COPD and heart failure. So as for the recommendations, JNC 8 recommends initiation of pharmacotherapy treatment to lower blood pressure for the following patients who are younger than 60 years of age with a systolic blood pressure of 140 or higher, or a diastolic blood pressure of 90 or higher. And we need to initiate treatment with losartan, 50 milligram once daily, and increase to a target dose of 100 milligram once daily. In monitoring, we need to monitor for efficacy for improvements in blood pressure, prevention of and mortality and morbidity. For safety, we need to monitor the heart rate, BUN, serum creatinine, potassium, baseline LFTs, jaundice and hepatic failure, and electrolyte abnormalities. We need to monitor the serum potassium and renal function within 1 to 2 weeks after initiation of therapy, according to the ACCF AHA heart failure guideline recommendation. We need to monitor patient adherence to the therapy. We need to caution patient about salt in diet and the use of OTC products that may exacerbate hypertension. And we need to warn the patient about dizziness, feeling tired or weak. Second recommendation is to continue the treatment with the metoprolol succinate 200 milligrams daily, and we need to monitor for efficacy the blood pressure, and for safety we need to monitor the heart rate, heart rhythm, and blood glucose. In patient counseling, patient needs to be educated on monitoring blood pressure and be advised to be adherent to the medication therapy. Patient needs to be encouraged to avoid alcohol consumption and notify the doctor if the patient experiences any chest pain that is new or worsening, and slow heartbeat and shortness of breath. Thank you very much.